So predictors of treatment response in ALK positive metastatic NSCLC. Next. So you have already heard from, already heard about this. So ALK positive disease is a distinct subset of NSCLC. So patients are more often a non-squamous histology, either a neighbor or a former smoker, relatively younger patient, females, and especially patients who don't have a EGFR or a KRAS mutations. So clinical characteristics do not always predict the presence of ALK positive NSCLC, but we see that these patients many a times harbor a asymptomatic brain lesion. So before starting the treatment, probably it is wise to have a baseline MRI brain. Next. So we have already seen these slides. So with first generation moving to second generation and third generation, the potency, the CNS penetration, and the coverage for ALK resistance goes up. Next. So the mechanisms of resistance can be an amplification of the ALK fusion, can be a mutation in the ALK kinase domain, and there are different bypass signaling. Next. So how do you select your ALK inhibitors? So based on the systemic activity, based on the CNS activity, definitely the safety profile and the resistance profile. Next. So coming to one of the paper which got published in Cancer in January 2012. So this was a correlation between the percentage of tumor cells showing an ALK gene rearrangement, signal copy number, and response to the first generation, that is crizotinib, in the FISH positive ALK. So the background was that FISH consistently showed rearrangement in less than 100% of tumor cells in ALK positive. Increased copy numbers of fused and rearranged signals also occur. And here correlations are explored between the percentage of ALK positive and signal copy numbers and their association with response to ALK inhibitions. The methods that 90 patients of ALK positives were evaluated, the percentage of positive cells, patterns of positivity, and copy numbers of fused, isolated red or green signals are recorded. But 30 patients had received a crizotinib. Next. So the results: increased isolated red signal copy number correlated with the higher percentage of ALK positive cells. Mean fused copy numbers was negatively associated with these isolated red signal copy numbers. So neither percentage of positive cells nor copy number correlated with maximal tumor shrinkages with crizotinib. So the conclusion of this publication was that the strong association between increased copy number of key ALK signals and percentage of positive cells are in ALK tumors is maybe a technical factor rather a biological factor. So in ALK positive tumors, neither the percentage of positive cells nor a signal copy numbers appears to be informative variables for predicting benefit from ALK inhibition. So this was a negative paper in 2012. So we'll move to 2021. So next. So before that, so yesterday we had a discussion on ALK positive and the PD-L1. So PD-L1 expression is positively associated with the presence of ALK rearrangement. So upregulation of PD-L1 by the EML for ALK fusion protein can induce apoptosis of T cells through the PD-1 and PD-L1 excess. Next. But what happened? Alectinib versus alectinib and atezolizumab did not improve responses, neither improvement in the PFS. Next. So lorlatinib versus lorlatinib plus amivantamab again did neither improve responses or the PFS. Next. So ceritinib alone was no better than ceritinib plus nivolumab. Next. So if you talk about the safety concerns, so the rash hepatitis was significantly high. So the combination of ALK and the various immune checkpoint inhibitors did not actually go the right way. Next. So moving from 2012, now 2021, this ELCC paper, which was a poster presentation from the Turkey group. So the predictors of treatment response in ALK positive metastatic NSCLC. Next. So this was a retrospective study. So evaluated the data of ALK positive metastatic NSCLC patients treated with an ALK inhibitor. So the clinical, pathological, and treatment data were assessed by a binary regression analysis. The cutoff value of ALK positivity rate in tumor cells to respond to the treatment by ROC analysis was also evaluated. Next. So you can see the baseline characteristics. So 68 patient, median age of 55. So 53% of them were male, and around 90% of them were a true adenocarcinoma, and de novo metastatic disease in around 82.4%. Next. So treatment received before these patients, so most of us, what we do in India, so most of these patients before these reports were available, so more than 50% of the patients were started with the platinum combination chemotherapy before they were switched over to an ALK inhibitor. If you see the group, so ALK was more than 50% followed by crizotinib, and there was hardly any patients in the ceritinib. Next. So the results, median follow-up was 21 months, median overall survival was 39.2 months, and overall response rate here included CR plus PR was around 66.2. So cutoff level of ALK positivity ratio in tumor cells for the responses were 30%. So the binary regression analysis showed on the left-hand side, what are the predictive factors to response to ALK inhibitors? So you can see the gender. So females did better than the males. You can see the p-value, ALK positivity rate, so and the number of metastatic sites. So the non-predictive factors to response to ALK inhibitors was age, primary site, so left or right didn't matter. So adeno versus squamous did not matter. De novo metastasis did not matter, and the type of ALK inhibitor also did not matter. Next. So from this poster presentation, that concluded that positive predictive factors for response to an ALK inhibitor is a high ALK positivity ratio. So in 2012 paper, it was a negative, but this showed a positive. Female gender did well, and those patients who had a less than 3 metastatic site, so they have done better. Next. Thank you so much. So we are already into the second wave. So I request and pray that all of us stay safe and sound. Thank you so much.